Good morning to everybody. I'd like to welcome everybody to the latest event in a series put on by the Center for International Private Enterprises Anti-Corruption and Governance Center. The series is on COVID-19 and corruption. Today's event focuses on COVID-19 and corruption in the health sector. If you have any questions for our panelists today, please type them into the chat section of the Ring Central interface, and they will be read out after the panelists finish presenting. I also want to let everybody know that we're recording this session and that we will share it on CYP's YouTube page. So if you miss out on anything, you'll be able to see the event there. And then also, I just want to say thank you very much for joining us this morning, and we look forward to having you. Our executive director here at CYP, Andrew Wilson, will give a few introductory remarks now. And I will.
Thank you, Peter. And on behalf of the Center for International Private Enterprise, I'd like to welcome you to Exploring Corruption Risks in the Health Sector, a virtual event featuring speakers from Cairo, Berlin, and California. This conference is the 7th in a series of public events on COVID-19 and corruption, which is being organized by our Anti-Corruption and Governance Center. Today's event focuses on healthcare, a theme that is at the forefront of all of our minds, especially those of us who work in the world's emerging markets. For, after all, these are the places that are the most vulnerable both to the ravages of the disease itself, as well as the secondary impact on fledgling democratic institutions in those countries. Today's subject of corruption in a health crisis is a broad and nuanced one. That's because corrupt payments are often used to expedite bureaucratic processes or to go around ordinary rules and regulations. Making such payments is rarely justifiable. One of the few acceptable defenses for paying bribes, or speed money as it's sometimes known, is to deal with matters of life and death like health emergencies. So, as you can probably tell already, today's topic is a complex one. I'm anticipating an especially interesting question and answer series after the presentations. So at this point, I'd like to hand things back over to Peter Glover, who will be hosting our event. Peter, back to you.
Thank you, Andrew. I didn't properly introduce myself at the start, but just so make sure that I do. I'm Peter Glover, a program officer at CYP's Anti-Corruption and Governance Center. But thank you very much, Andrew. And I don't want to sort of delay any longer. Without much further ado, I'll jump to our first panelist, Sarah Steingruber, who is an independent global health consultant who is focused on corruption in the health sector through her work at organizations like Curbing Corruption, Transparency International, and U4, all of which do really some of the most fascinating work on this topic. So yeah, really exciting stuff. And I would also recommend reading her recent writing on the Global Anti-Corruption blog and listening to her recent appearance on our favorite anti-corruption podcast, Kickback. But okay, Sarah, please take us away.
Great, thank you, Peter, and to Andrew for those initial remarks. And thanks to everyone for joining today. I hope you're all keeping well and healthy. I'm going to share my screen with you here for my presentation. So can everyone see, I hope? Great. So I've been asked to provide you today with an overview of the risks and vulnerabilities regarding corruption in health, and specifically looking at the COVID-19 response. Now, I've been given a very short amount of time to do this, so I'm really going to be able to just skim the surface. And I'm hoping that through the question and answer, we can delve into a bit more detail. But I will start by giving you sort of a basic idea of corruption in health systems, and particularly looking at why health systems are vulnerable to corruption. And I'll start by saying that no two health systems are the same. We tend to think of them as being quite monolithic, But in fact, they have different funding and reimbursement mechanisms, different governance structures, different procurement procedures, different regulations, and they have very complex supply chains as well, which are very global and very lengthy. And this is to say that while there may be similar decisions made within health systems, they are often done by different authorities or individuals working within them. There are many different decision-making points. And this, of course, increases our vulnerabilities or the vulnerabilities and opportunities for corruption to occur. When it comes to how much money is spent on health, the estimate is that about 7.5 trillion is spent annually. This is a mammoth amount of money, and very conservative estimates are that about 6% of health care spending is corrupted. This is about 450 billion US dollars each year. Now, when we think about how much money the WHO has estimated for us to achieve universal health coverage, that's about 370 billion US dollars. So there's a lot of funding, and there's a lot of funding that's falling through the cracks. And this gives us an indication of why it is that, in light of the COVID-19 outbreak, why our pandemic preparedness has been actually quite, in some regards, quite poor. Then if we look at issues of corruption in specific functions of a health system, when we look at public procurement, there are estimates that 10 to 25% of funds is in fact lost to corruption. In health systems, in high-income countries, as much as 30% of the annual budget is spent in public procurement. And in low and middle-income countries, that can be upwards of 50%. So that is a huge amount of funds that is being diverted from the get-go, essentially. When we look at the sort of service delivery level, we have recorded that 17% of people worldwide state that they paid a bribe when interacting with the healthcare sector. And now we tend to think of bribery as being sort of a global south issue, but in fact, it happens in healthcare systems all across the world where bribes are taken. As an example, in Austria, they have a phenomenon called Couvert-Medizin, where in fact, in a very, very crude way, cash is stuffed in an envelope so people can jump queues. So it's happening everywhere. And then the final thing I'll say about corruption in health more broadly is that anti-corruption transparency and accountability, so efforts to actually improve or to tackle corruption in health systems, is often ignored. So it's seen as part of just business as usual. It's insufficient, or it is ineffective. So that means it's actually creating opportunities for corruption to occur. Now, talking about corruption risks and COVID-19, I find it can be really helpful to compartmentalize this into the 6 building blocks of the health system. So as I said before, there are no two systems that are the same, but they do have similarities, and you can be pretty confident that each health system in the world will have these basic building blocks within them. So when we talk about COVID-19, what are the risks? So under service delivery, in addition to regular risks of corruption that we see, we also are seeing now examples of profiteering. So for example, disinfectant is being purchased and then sold for very, very high prices, or people are paying bribes to get out of quarantine. Then we have issues in the health workforce where there's the risk of misinformation, or so-called fake news, that's leading to disdain for healthcare workers, and it reduces the public trust in the system. This can increase healthcare workers' fears to attend their jobs, so it can lead to absenteeism. And this is something that has also been seen during the Ebola crisis in West Africa from 2013 to 2016. Now, when we get to the point of essential medicines, this is where my kind of alarm bells start to go off. So what we really need to be concerned about is what I'm calling Tamiflu 2.0. For those of you unfamiliar, Tamiflu is a drug that was developed in the early 2000s for influenza. And it was purchased en masse by governments. They spent millions and millions to supply or to procure this treatment, but in fact turned out that it was done by the Cochrane collaboration later, a meta-analysis that found out that this drug actually was no more useful than paracetamol, or Tylenol, as it might be called in the States. And this was because the data was not made transparent from the get-go. So it essentially, the good results were provided and the bad results or the neutral results were not. So it gave a very dishonest view of what the success of the drug was. So I'm very concerned that the next big blockbuster that will help to tackle COVID, whether it be a drug or a vaccine, could also be not subjected to sufficient scrutiny with regards to the clinical data. There's also the concern about unequal access due to high costs and companies' desire for high profit margins. As I said, the next drug or vaccine will be the big blockbuster, perhaps the most profitable that we'll have ever seen. And if the R&D costs, which are typically not made available anyway, if they're not made available, it's very difficult to understand what proportion of the investments into discovering that drug were in fact public investments, and how much were made by the company, and then how to relativize that to how much the drug should actually cost. And the high cost is actually a serious concern, especially when we think about ensuring that there is universal access to whatever the treatment ends up being. And we've seen already some concerning behavior around this. About a month and a half ago, the company Gilead Sciences had their drug remdesivir, which has now been purported to be a sufficient, at least moderate treatment for COVID-19. It was originally registered, tried to be registered at the FDA as an orphan drug, and that status prevents the government in the US from being able to negotiate prices. So we're already seeing a bit of that happening. That's been rescinded, of course, but only due to a very strong civil society reaction to it. Then the final concern here is abusive R&D regulations. So poor study control protocols can be approved, and there is a lot of concern that due to the haste that not all of the protocols will be appropriately followed, and the Helsinki Declaration could be violated. And then also things like suggesting, which has already been done, that African states can be a testing ground because it's cheaper. So these are strong concerns of mine with regards to essential medicines. Looking at health systems information, my concern here, or the concern here, is that there's a failure to report cases, so we won't actually know the beast that we're up against. And we've seen this happen in China, and many of you maybe have also seen that there has been absolutely no budge in their case and fatality rates, basically since a month or so, which is difficult to believe. And so if we don't know the beast that we're up against, we can be very poor responders to it. Moving on to health financing, of course, there's corruption risks for procurement, which everyone's quite familiar with. And this would be very typical to other sectors. The unique element here being, of course, that there's such speed and volume of procurement, and the cost. I mean, when we think about the cost of a ventilator and how many ventilators are being procured and the ways in which they're being procured, there's a lot of gaps and concerns there as well. And because of the haste, it makes it very difficult to ensure that there's sufficient quality of the products being procured. And then here finally, we have issues of oversight over the serious amount of spending that's now happening on overseas development assistance from various countries and funding organizations. So it's a similar situation with procurement. There needs to be very, very good, transparent oversight over this spend. And then finally, with the building block of leadership and governance, the concerns here are around things like power grabs, so using the outbreak as a distraction to increase power, to politicize the outbreak for political gain, disabling the Justice Department so that those who need to be held accountable are have impunity. And then, of course, using the outbreak as an overall distraction to push through certain partisan laws, or to turn your back on other forms of corruption and allowing it to flourish. Now, again, this is a really kind of broad sweep about many of the concerns and risks of corruption during the outbreak, but I'm hoping that we'll have more time in the Q&A to discuss. But I'll leave you with as we go into the other presentations are the two big questions that I think when it comes to dealing with corruption in health, and what we need to also think about when it comes to the COVID-19 response is, what are your overall objectives with regards to anti-corruption, transparency, and accountability? So what are you trying to achieve with these measures? And then also to ask yourself what corruption is most likely to happen and what can cause the greatest harm. And I've said this in the past, the objective of a health system is not to do good anti-corruption, it's to improve human health. And so that should be the objective and the goal that we follow. So I think I will end on that and turn it back over to Peter.
Thank you, Sarah. Thank you so much for that presentation. And I'd like to remind everybody that we're in a 90-minute session on COVID-19 and corruption in the health sector, put on by the Center for International Private Enterprise. If you have any questions for the panelists, please put them in the chat function. For me, it appears on the bottom right-hand side of my screen. Or also at the very bottom, there's a bar that says chat. And yeah, we're putting aside a lot of time for Q&A. And I know that I already have a few questions bubbling up after Sarah's presentation, but for now, we're going to turn it over to Mustafa Hunter. He is an international expert on health system governance, and he currently works as a senior anti-corruption consultant with UNDP. And I know that we've been talking to Mustafa for a while, but about some of these issues. But so I will go ahead and share the PowerPoint and hand it over to Mustafa.
Okay, thank you, Peter. And I will just notify you to change the slides then. Thank you, everybody. My name is Mustafa Hunter. I'm originally an eye surgeon, but then for me, it's like a passion. So I stopped practicing medicine and focused into dealing with health system governance for the last 15 years. And over the last 5 years, I've been intensively working on issues related to corruption in health with the UNDP. So let's start trying now. If we look into, just Peter, can you switch to, it's on, do you hear me?
Yes, we hear you.
Okay. You hear, perfect. And the video also is switched, or it's you? Okay, perfect. So, okay, so if we start looking into corruption from a risk perspective, and especially into the time of the COVID crisis, we have crisis and corruption. It's a vicious circle. So if you look into this slide, you look like it. So we have poor accountability and vulnerability to creates vulnerability to corruption. Peter, can you check, because I do not see myself in the video? Is it so I'm seen in the video? Just a quick question.
I'm just checking.
Oh.
Do people see, sorry, if somebody could post in the chat, do people see Mustafa's video at the same time as the slides?
Okay, and because it replaced, yes, okay, perfect.
Yeah.
Okay, can you switch to the slides then? So, so if you look into this poor governance and accountability, we look poor governance and accountability gaps. It creates vulnerability to corruption. And then vulnerability to corruption creates systemic corruption. And then systemic corruption in itself creates poor governance and accountability gaps, because you create these vested interests and these circles. And so they are feeding one another. And then if you look into the COVID-19 as a crisis, then we have this response and recovery. And this package of poor accountability, vulnerability to corruption, it undermines the capacity to respond and recover. So exacerbates the crisis. Not only that, but I will come later on to how even this COVID-19 crisis exacerbates even the crisis, the accountability gaps and corruption. So at this point, we have this vicious circle that we really need to intervene with. Can we move to the next slide, please? Then. So what happens in crisis, and just like a question, is this effective? I've seen a lot of anti-corruption measures, like and things that happen during the time of crisis. First, we have like focusing mainly on post-event detection, counting fires. This happens, rather than being proactive and looking into prevention rather than just focusing on punitive approaches. Lots of times we deprioritize anti-corruption efforts, which means we start saying, okay, let's car park now. People are dying, as if corruption itself would not cost us money and lives. So health people tend to say, okay, please governance people like that. Governance is not a luxury that we car park at these levels. Sometimes you start saying, okay, we have to accept corruption so that we can move on with the crisis response, which is not also good, because you send a message for rationalization, for like it's a crisis, so please move forward. Then sometimes you use this corruption, what I would call risk narration rather than risk assessment, which you're saying that this might happen, rather using a systematic analysis. We recommend sometimes these abstract, broad, macro level governance transformation, and this is like telling a patient with cancer and who got recently a heart attack, if you eat well and play sport, you will be healthy, which is then the same notion, to my opinion, when we say, okay, building good, strong institutions will reduce the vulnerability, and using this when we have systemic corruption at the time of crisis. Sometimes we do this blanket recommendations, use transparency, use things, rather than targeted and focused. We think of one size fits for all. We don't prioritize the interventions. We cannot address all these risks. So we need to have methodologies to use this and address this and prioritize it. And there's a complete sometimes disconnect between the health sector and the anti-corruption community. They are divided between one another. So let's move to the next slide and let's look into being proactive. And being proactive, and I really like the term, the mother science. Whenever I do something, I just go, where is the mother science? And here we're trying to have a systematic approach to prevent corruption as a threat or an adverse event and preempt its harms through cost-effective interventions. And the mother science of that is risk management disciplines. And here I would like to focus that we are looking into a risk management science as a mother science rather than anti-corruption, and we've been trying to adapt this to that. Risk management disciplines are very well advanced. The main four reference points are the ISO 31000, the Institute of Internal Auditor International Professional Practice Framework for Internal Auditors, the COSO framework, Community of Sponsoring Organizations for Enterprise Risk Management and for Internal Control, and the Open Compliance and Ethics Groups, the Governance Risk and Compliance Package and Principal Performance. So these are sciences. And these sciences would look into the definition on the right, which is the possibility of an event occurring that will have an impact on the achievement of objectives. And in this case, risk is measured in the terms of impact and likelihood. So let's look into this risk management, how it looks like. Next slide, please. So risk management starts by the identification, and it's a cycle, and it starts with the identification, which now we have like it's corruption. Whatever it is, bribe, embezzlement, we can put this identifier. But we need to move into the scope and context, tailoring it to either a function, entity, or a process. And then we move into an analysis, which goes into impact and likelihood. And we should have methodology to be able to populate a risk heat map as on the right side, so that we can measure and assess a bit of the risk severity, which is a key point in helping us to prioritize. And then we need to shape our response. And there are 4 types of responses, which is avoid, accept, transfer, or mitigate. Avoiding risk sometimes is difficult if we will interrupt a health program. And as the colleague said, our objective is health. Accepting risk does not mean we're accepting corruption. It's just like a certain appetite. And finally, we move into the monitoring. And here I'd say, like any risk assessment should go prepare for that. Earlier as a surgeon, we had this quotation, like diagnosis without the treatment is just intellectual curiosity and entertainment. And we now really, if we're not doing an assessment, and using the term assessment should lead us finally to tailor a response and then to monitor it later. And we should not stop just on the first step. The next slide, please. So what happens in a crisis? The crisis exacerbates everything. How this happens? First, like the drivers and incentives, we have financial pressures. People are getting low payment. There's low income, economic hardship, uncertainty about the future, combined with scarcity of resources, like the availability of health services and products, access to drugs, payment for suppliers, combined with increased flow of funding, especially aid, government subsidies and corporate donations. And if you imagine now on the other side, we have the restraints are lowered, which then pushes, like people to abuse their entrusted power, the drivers, and the restraints were loosened them. We have disruption of the system, bypass of regular procedures, loosening of regulations and controls, granting extra authorities, obstruction to the work of anti-corruption agencies, tendency to marginalize the importance of governance, and then combined in increasing this individualism, opportunism, and of course, like in the fraud triangle of the chance for rationalization. If we combine this and decision makers, and as we say, like it's about a decision action point, different decisions within the system, we have a very high likelihood that corruption will happen. Moreover, can we move to the next slide? And then we're looking also that the crisis even exacerbates and amplifies the impact. Citizen health is the point where they're vulnerable, endangered. Health workers are exposed. Health systems are disrupted. Public trust is critical at that point. Resources are limited. Inequities are exacerbated, and communities are vulnerable. So we have also a high impact. Move to the next slide then. So, and we have special areas at risk in the health sector, which is like policies and guidelines, research, registration and licensing, supply of medical products, service delivery, granting privileges and hospitality and license. These are like the areas where I think the future would be much higher. Like we've seen examples of interference, a bit of in the policies and guidelines for special interest. As the colleague highlighted, research would be very vulnerable. The registration licensing for drugs. Supply of medical products, of course, we've seen also PPEs, which are poor quality, and service delivery, access to certain health services, access to privileges like, moving during confinement. And one thing I know that we should really put an eye on in the future is hospitality license and inspection, where we're granting people for restaurants and hotels the health authority to open that. So this would be a high risk area also expected. Can you move to the next slide? So looking into crisis, a crisis is not only not only bad because it offers an opportunity window for reform, because sometimes you have political will for response and reform. We have public pressures, economic pressures. Such crises also offer exposure of deficits, disruption of structures, acceleration of certain changes like digitalization, and opportunities for collective active action. So we need to move forward into using this also as an opportunity. So next slide, please. So what we've been doing actually, so what we've been speaking about is like adapting this with the UNDP. We've been working for the last 4 years in developing a methodology and adapting it to use risk management sciences into concrete decision points. Unfortunately, due to the time constraints, we'll not be able to go into the technicalities of it. However, this runs to also national multi-stakeholder teams. You've seen in the photos here, you can see like how we worked in so many countries in the Arab regions in Africa in different times of disruption. And the idea is like, we need to build capacities in managing risks of corruption for us to be able to move forward, in order not to sit there after 3 years and just document what corruption happened today. And to sum up, like to conclude, these are the key messages. Like if we want to prevent something in advance, this is risk management. Risk management is an established science. We need to think the full risk management cycle. We need to be able to build risk heat maps and decide on residual risk, and to move forward with that in order to be able to make targeted intervention. The cost of controls in our response should never outweigh the risk itself. And we're working on, over the coming 2 or 3 months, so many knowledge products and experiences will be shared and made available. Next slide just.
Okay, thank you so much, Mustafa. I think that sort of, yeah, that was a fascinating dive into sort of the risk management approach to looking at corruption in the health sector. I'm going to stop sharing and start my video, but as a quick reminder to folks, as questions come to you, please submit them through the chat function. I think that we already have a few interesting questions. We're leaving a healthy amount of time for Q&A, so please make sure to have sharp questions. We've found that this kind of event with sharp questions, we get a lot of fascinating information. But so moving on to our last panelist today, Tim McKay is a professor at UC San Diego. Tim has a background in health compliance, and his recent research looks at global health governance, counterfeit drugs, online pharmaceutical scams, health IT policy, a lot of really fascinating topics that I think Mustafa was sort of referencing in one of his last slides. So that was a nice segue to have Tim now take us away. I'll switch to PowerPoint. Yeah, one moment for the PowerPoint.
Great, I hope everyone can hear me okay. This is Tim. Thanks to Peter and SIP for the invitation to talk about anti-corruption in the context of COVID-19. Really some fascinating work that's being done, and want to disclose that me, Mustafa, and Sarah have worked together previously, so it's great to see you guys on the panel and also have this interaction. So next slide, please. Yeah, next slide again, sorry. So the first thing I wanted to put into context is where we are with this particular pandemic. A lot of people are comparing COVID-19 to the Spanish flu in 1918. I want to note that that was a period when the radio was basically just being introduced. There was actually, commercial radio was just starting, and there was no electronic television. Fast forward to 2003 in SARS, which was considered the first globalized outbreak of the time because it represented a new risk to the world where a disease could travel from one hotel in Hong Kong and spread, to multiple countries in just a few weeks. So this was a representation of the fact that our economies are more interconnected, trade is more rapid, and that disease, of course, have more lethality because they can travel the globe so quickly. And this was also a period of time in 2003 where there was no such thing as Facebook, and things like social media were just emerging. Now, fast forward a little bit farther to 2009 with the H1N1 outbreak, which is arguably the first post-digital outbreak of its time, but post-digital pandemic. And this was a period where smartphone access was rapidly expanding. The Apple App Store had just launched just a year before, and we were just starting to really adopt these digital technologies. Now in COVID-19, in 2019, over 50% of the world's population is on the internet. And Facebook, just as one example, has 2.5 billion monthly active users, which, if they're all real people, would constitute the largest population of any country in the world. So go ahead. Next slide, please. So there's a few animations here, so bear with me a little bit. You can click through them. So we're going to talk about COVID-related cybercrime, because one of the things that I've mentioned is we're now really in a post-digital era. And one of the things that has been great is that we have all this technology to help us do things or distract us or enable us to be more productive, but it's also enabling a lot of cybercrime. And that's particularly in the context of this COVID-19 outbreak. So first, here's some headlines. Here's one that says that Americans have lost 13.4 million in fraud linked to COVID-19. So beyond the digital component, there's also a lot of existing fraud that's going on. That's a report from the FTC in the US, where I think about 18,000 people have reported fraud-related COVID-19 scams. There's, of course, existing cybercriminal networks that are activating to take advantage of the COVID-19 crisis and doing scams that relate to unemployment claims in the US. So this is an example of an African cybercriminal network which has been activated to file fraudulent claims for unemployment. And there's a lot of different COVID-19 related stimulus money that is likely subject to a lot of fraud and abuse. And that's unfortunate because obviously that means that the businesses that need it may not be getting it, and the loss of taxpayer money and public money associated with that. Click through. Again, this is another headline that says that the FBI has seen a 4-fold increase in cybercrime related reports to COVID-19. Next slide, or next animation. And here are some things from the UNODC that focus on specific areas, such as people that are particularly vulnerable to online fraud and extortion. The risk that now that more of us are at home and more of us are on our computer, that obviously the exposure to cybercrime is higher because we're on our computers more, and that there's really not enough specialists to kind of deal with this issue. One quick example is Facebook's content moderators, the people who make sure that there's not a lot of bad stuff on Facebook, have got sent home, but a lot of people, them can actually not do their job from home because content moderation is very tightly controlled by Facebook. You have to be on site, you have to be on their computers, etc. Some of the front lines to remove this fraudulent content is actually gone. Next animation. So there are plenty of US agencies and different organizations that have fraud lines that are requesting consumers to let them know if fraud is occurring. But of course, self-reporting has its limitations. Next animation. And then some other examples of websites that have actually been taken down by the Department of Justice and Homeland Security investigations because they're involved specifically in illicit products. And then some of our own work. Go ahead, Peter. Where we've looked for fake testing kits online and other COVID-related commodities, which I'll go into in just the next few slides. Next, Peter. So what we're looking at specifically is what we call the parallel infodemic. And an infodemic is a term that's been coined by the WHO, again, in the context primarily of this COVID-19 outbreak, where there's an overabundance of information, some of it being accurate, but some of it that is not trustworthy or reliable. So Sarah discussed the issue of misinformation. The WHO has a Mythbusters website that talks about all the myths that are out there about COVID and trying to, debunk them essentially. And there's some crazy ones out there, like your typical, there's one that was circulating about how cocaine could cure the coronavirus. So the WHO is actively trying to combat this misinformation, but because these digital networks are so diffuse and so their scope is so large and a lot of the information can really become viral really quickly, it's very hard to combat this activity. The stuff that we focus on from a research perspective is really this sub component of it that really focuses on selling illicit products online. But again, cybercrime relates to all types of cybercrime, including online frauds, robocalls, phishing scams, and other types of activities that are trying to get people's money essentially through these digital platforms. So the research that we do primarily focuses on using big data, machine learning, and data visualization to identify and characterize and also report illegal sales of online products related to COVID, which again include fake cures, suspect testing kits, and counterfeit drugs. Next slide. So a lot of this work stems from some previous work we've done on corruption, where we've used some of the same techniques of machine learning and topic modeling to identify self-reporting of corruption related activities. So this is a study that we published about a year ago. We have another one that's currently under review, where essentially we're looking at Twitter and identifying self-reporting of mostly bribery. Most of the content we've detected are people talking about their experiences with police bribery or judicial bribery or administrative bribery. And self-reporting it potentially to warn other users about the risks. And this figure in the middle shows the geolocation of some of those tweets, which include the US, but also other countries which have a higher propensity of corruption, such as in West Africa and India. So we've taken a lot of this initial work that we've done, including other work we've conducted to detect illicit drug dealing, and applied it to the COVID outbreak situation. Next slide. So what we found is, what you wouldn't necessarily call corruption, but would be fraud and abuse. And that relates to all of these fake testing products that are being sold online, testing and treatment products. So in the upper left corner, you see a rapid test kit. We see thousands of these posts. Even I got a LinkedIn request from someone saying, we are a supplier of COVID-19 rapid tests in China. Are you interested in it? And I get requests like this. I got one this morning as well. So, these scammers are often targeting people, because there's not much access to testing and people are worried potentially about, being infected by the disease. Other examples on eBay, this one we found where a test is actually labeled as FDA when the FDA has not approved any home tests at all. So there's no approved home test. Things like this tweet where it says Dr. Coronavirus. So it's pretty obvious that they're misrepresenting who they are. And then this example from the dark web, because the dark web has also been activated as a marketplace for scams related to COVID, where a seller is selling recovered patients' blood plasma. And this seller, what's interesting is some of the transaction history looked through. Previously, they were selling deer musk, which is used to hunt deer. So probably not the best person to buy blood plasma from on the internet. Next slide. So even though these are kind of forms of fraud and abuse, a lot of our previous research into illicit drug dealing online indicates that a lot of this activity, online activity, is actually related to organized crime and organized crime syndicates. And so a lot of this fraud and abuse may roll up into more organized crime or more systematic corruption. And that's, of course, a problem, particularly when it comes to drug access and also making sure that people get the treatment they need. So in the context of solutions, we've built this dashboard here on the left that has displayed a lot of the data that we've collected, and we've shared it with the FDA and the World Health Organization so that they have it as a tool to potentially identify risky behavior online and to inform the public about the risks associated with that. And we built a blockchain component to it as well in order to establish provenance of the data collection process, which is a separate technical feature. But blockchain has also been discussed in the context of anti-corruption. So if people have questions about that, I'm happy to go into that as well. But I will close with just saying that digital technology offers opportunities for corruption and fraud and abuse, but also offers opportunities for solutions that can combat it. Whether there's a net benefit of technology, I'm not sure. It seems a lot of the misinformation is kind of crowding out the good information, particularly if misinformation comes from our world leaders, including in this country. Then it makes it very difficult to address those issues. So I'll close with that and look forward to the conversation after.
Thank you very much, Tim, for the really interesting dive into the work that you're doing. I want to give a very big thanks to all of our panelists today, Sarah, Mustafa, and Tim, for their fascinating presentations and thoughts. I'd also like to remind people that this is part of a weekly series. This session is part of a weekly series put on by CYP's Anti-Corruption and Governance Center on different topics related to COVID-19 and corruption. If you're interested in this subject, please reach out to us either by email at acgc@cyp.org or over Twitter. Our handle is at cyp_ACGC. And we will sign you up for a WhatsApp channel devoted to this topic. We have sort of curated daily updates on what's out there, what's being written, and the kinds of events on this topic. I want to give a special, I want to now jump to the Q&A. If you have questions, please put them in the chat function. I'm going to stop sharing my screen and jump over to the Q&A. If you want to ask a question to a specific panelist, please do so in the question. You can direct it. You can say, for Sarah, I would like to know such and such. For Tim, I'd like to hear such and such. Yeah, please post your questions. And I will start with one. Well, I'll start with a clarifying piece. Roberta Lam asks, will the slides be available to the attendees? We will post the entire presentation on YouTube on CYP's YouTube channel. And so all the slides will be available there. But if you're interested, you can follow up with us and then we can get them to you as well if you'd like to follow up by email. Okay, I'm just gonna go back through the questions to the very beginning. Okay. Okay, so this question, the first question comes, and I'll read out the questions. But so the first question comes from Elisabeth Spitalaki, and this is for all the panelists, but do you have an example of a policy on anti-corruption health procurement which was applied during the epidemic? For instance, the Commission's joint procurement. Do you think that any of these policies may be maintained in the post-COVID time after the pandemic has passed? I'd be curious to hear if panelists have thoughts on that question.
Oops.
Hi, Mustafa.
Hi. So, if you in this, like, just I would say, like, yes, there are several. The trial, if just I understand the question right, is that the trial to create a centralized procurement body, and also a consolidation of the donations, for example, like in some countries where you just create a committee that runs this procurement, or like some countries had already these bodies so they could use them. Some countries created this emergency mechanisms, and yes, I would say from my side, this can help and to become institutionalized for later on. You know, like this trying to make a central procurement body for at least for the government part is something that's existing in several countries that have been created as a mechanism of the crisis and can be later institutionalized in general to mitigate the risks of corruption in the public procurement thing. I just want to highlight one thing is that the supply of medical products, it's a full cycle. So I would not just send a message that you should only focus on the procurement. It starts by the demand management and the supplies, the procurement, and then the distribution, and finally the dispensing till it reaches the end population. So please think of a full cycle rather than focusing only on procurement, and maybe using this emergency supply mechanisms, like, for example, sharing the risk with other bodies that can help you, for example, either companies or NGOs with a strong, or international agencies with a strong supply chain and strong compliance can also help, and can also be institutionalized later to secure and track and trace your supply chain. So it's not only about procurement, it's about the demand, the procurement, and the supply and the dispensing cycle. I hope this answers.
This is Tim as well. I'll just mention one quick thing. At the beginning of the outbreak, there was a lot of policy issues with a lack of coherence. So when PPEs were not available and masks weren't available, a lot of countries were hoarding products and not enabling the supply chain to kind of disseminate protective equipment in an even way, especially when there were particular countries that maybe held more power over a particular company because it was within their jurisdiction. So I would say that there was a lack of coherence at the beginning, and that there's more policy coherence now when it comes to enabling a global procurement and having countries agree of which products should be shipped and which products should be available. But this is one of the ongoing challenges we have in an outbreak, is that countries are going to want to hold back equipment or supplies that are really critical. And I don't think we've addressed that issue well enough, especially in the context of the outbreak and the very beginnings of the outbreak itself.
And I'd just like to chime in, but coming from a bit of a different angle. So rather than what's been implemented now with regards to procurement, thinking of sort of when the so-called blockbuster treatment or vaccine does come about, and the negotiations that surround sort of the setting of the price for that, which has a direct impact on procurement and the overall costs and expenses of states. There is a mechanism that has been used by a number of countries within the European Union. It's called Benelux. It's Belgium, the Netherlands, Austria, Luxembourg. I think Ireland has come into the mix as well. And they do joint price negotiations. It's been used with varying levels of success, but it is an interesting mechanism to consider for when the vaccine or treatment is available, for countries to kind of band together and ensure that not one country, which is considered a benchmark country, for example, regarding price, has a much higher price, but that there's joint negotiations to ensure that everyone has equal access to the treatments.
Great, thank you to all the panelists for their responses on that. And I think sort of one thing just that also is in our mind is something that Sarah mentioned, which is, right, the risk that authoritarian or non-democratic regimes may use this as an opportunity to change policies in a really negative way, in a harmful way, and keep those changes in place. Just something that occurs to us as well. I have a question from Dana Berenger. And she's really interested in corruption in vulnerable populations. And she asks, how do you think corruption, specifically stemming from COVID-19, is impacting specifically the most vulnerable populations, those with poor social determinant of health indicators? What can be done to mitigate the corrupt practices that harm those vulnerable populations? Yeah. That's for all the panelists again.
So I'll just jump in really quick. One of the key vulnerable groups that have been identified and have been identified in previous outbreaks is particularly women, in fact, because not only are they make up the very large lion's share of the health workforce, and they're the ones on the front line dealing with patients in their most vulnerable states. But also women rely on healthcare systems arguably more often than men for reproductive purposes, for example. And you see that in previous outbreaks of Ebola, for example, there were increases in maternal mortality, and also because women are typically caregivers for family members, they were more often infected with Ebola, which is something that we will likely also see with COVID-19. What can be done to mitigate corrupt practices? I mean, these outcomes are sort of a result of the outbreak, and corruption, of course, exacerbates it by not having sufficient resources, etc., or for there to be resources diverted. As far as what can be done to mitigate, I think honestly one of the most important things is to have awareness, especially in countries where women's rights are maybe lacking. That there can be a lot of civil society beating the drum in favor of women, ensuring that they are protected. I'd be interested to hear what my colleagues have to say, particularly about that cohort.
This is Tim. I'll jump in and let Mustafa take the last say in this. When it comes to the digital space, there are specific vulnerability to particular population groups. One of the population groups that's focused on the most is those who are uninsured and don't have access to healthcare services. So a lot of these testing kits, a lot of these treatments that are being offered are targeted towards people that may not have adequate healthcare coverage. And of course, if they're getting a bad test or a bad treatment, then they're put in a cycle potentially of poverty, because they're not getting treated, they're not able to go back to work, and they're getting ineffective treatment or testing. We see a lot of that in the illicit drug sales online, and we're likely to see it the same way in the cyber crime related to COVID. Fraud and abuse and these scams usually target people of low socioeconomic status, and also those who really can't afford to be tricked or frauded to begin with. So I think there's definitely an impact on populations that are the most vulnerable versus populations that have the ability to gain healthcare access. And that's particularly a problem in the US.
Perfect. From my side also, I would add that definitely these vulnerable groups are much under pressure, and this is actually one of the reasons I switched careers back then, because these are really people who are punished. And if you look into corruption risks again, and back to the concept that it's about the likelihood and the impact, so definitely the likelihood of being extorted, being disprivileged, because when you have this scarcity and people start using their power structures and using influence, using connection, of course, vulnerable groups are much disprivileged, and they're much impacted because they're very highly exposed anyways. So if you do not have access to the drugs because they are skimmed, if you do not have access to the services that actually were not existing and now they are interrupted. So this is definitely one of the priorities, and how to integrate that is, maybe if I will explain later in answering other questions, is how you put your prioritization scheme in the risk management. If you put the vulnerable groups as a risk thing, then you can just look where they receive their service. If you put the gender coordinate, so the answer is we have to put vulnerable groups up front, otherwise they will disappear in this as a priority.
Great, thank you. Anything else, Tim or Sarah, to add? Okay, great. So we have a couple questions related to risk management in the health sector now. One is specifically, Mustafa, can you give us an example of the practical implementation of corruption risk management on the ground? That's from Gada Ismail. And then we have another question from Anwar, Ben Khalifa, which is again related to corruption risk assessment methodology, and whether there's an easy way to adapt it to dealing with an urgent crisis like COVID-19. And then building on that, could it be adapted to provide an ongoing risk mitigation measure instead of waiting for the end of a crisis to activate accountability and oversight mechanisms? So that's three big questions. But maybe sort of, Mustafa, you can lead off, and then maybe Sarah and Tim, you can jump in on sort of adapting sort of existing tools that are backward looking, and whether there are any that you use that can be sort of be present looking. Yeah.
So this is a very, very interesting question. Trick, of course, I'll try in this short time to wrap it up how it looks on the ground. So the whole idea is that if we use the definition of corruption as that abuse of a trusted authority in private gain, then it's about the decision and decision points. And Sarah clarified in the beginning of the presentation that healthcare is very full of decisions. So the first step is that it's all about identifying decision points. It's not about independent experts, but setting multi-stakeholder groups in country for the capacity and in-country ownership. Then these groups, you just scope it. You start by choosing, for example, the supply of medical product or hospital X, whatever entity process, you define it. And then you populate it in a process mapping exercise quickly, so you get a bucket of decision points along this process. For example, if you take a service delivery point, you will start by patient enters the hospital, registration, prescription of medicine. If you start by the procurement of drugs, then demand, how you assess the demand, and then you will actually be very able to identify where these decision points are placed in wherever part of the country. And then later on, you just start assessing the likelihood and the impact. There is a backbone drivers and restraints methodology. I cannot go through it now, but that looks into socioeconomic factors, the different restraints around this decision point. So you can get the risk profile. You populate it on the risk heat map, and then you start this dialogue on what are the priorities based on risk severity. So we have now the risk heat map. We start looking into how this risk severity looks like. But it's not only factor, as I said, we can use other variables like political choice, priorities. Then we discuss the response and the feasibility of the response to prioritize. For risk, we have 4 types of responses. The first response is to avoid risk. It's not nice in this time because then you terminate the program and this will create more impact. And I will go back to what Sarah was saying. Our objective is healthcare. So if I would just stop a program for health to avoid corruption, this is not a solution. Accepting risk, and it's not accepting corruption. It's just like you say, okay, it's maybe low likelihood, low impact. The best, of course, is transfers, and the best, of course, mitigation. Then you start tailoring it around the decision points. So examples in countries, you automate the process, you track, you maybe put a track and trace component, you use analytics to detect the red flags, and then you monitor. So this is how it looks like. It's a qualitative process, not so much evidence, but rationalization, like having a verdict and since their force. It would need, of course, just quick, I need to explain it more or showcase it, but it would need a webinar of its own. Regarding the crisis time question, it's a very good question. We're working on something like that and hopefully get it out soon, because in the time of crisis, you really need to make it quick. So you start having, you just get the things, you populate it quickly, you engage quickly, and you move quickly, and you generate evidence as you go. So you relax a bit. So you make a smaller team, make a quick risk heat map. And the margin of error in this thing is very flexible because it wouldn't make a difference so much. We're not like in putting numbers. So yes, you have to move quickly. And I totally agree that our job now is to tailor all this for the time of crisis, so that exactly we would look into what our 5 priority risks, for example, will focus on them and try to scale them so that we maximize the impact. The final point is that the cost of the response should not outweigh the cost of the risk itself. So should not put very expensive controls that actually interrupt the health, and the controls should not impact the health. This is like quickly, I hope it clarifies, but otherwise you can just connect with me later and we can put it forward.
I just also wanted to chime in very quickly and build on what Mustafa was saying. Actually, CIPE has developed an anti-corruption rapid response approach, which is a really interesting modality that could be merged with the UNDP approach, the risk framework. And I think that there's absolutely every need for an anti-corruption rapid response or rapid assessment approach that could be sort of built into the type of approaches that you see with surge teams for humanitarian responses. So in the event of such an event like the COVID-19 pandemic, that you have, as he said, sort of an influx of the critical experts that you require to do a rapid assessment, and then based on the back of that, once you've kind of entered into a bit of a like a stagnating period, that a more robust framework can be applied. Yeah.
And this is Tim. I'll add one quick thing, that risk-based assessments, especially in procurement and also in import and customs regulation, is pretty widespread use. So, and also in fraud and abuse. So it's not that you look for everyone that might be involved in fraud and abuse. You look for decision points and those clusters of groups that have the highest risk and are in the position to make decisions. And then you look for patterns, and that's all related to the accessibility of data. So initiatives like e-government, e-procurement, things like that, that can provide additional data on these decision points within the context of a risk framework can be very powerful, especially if they're automated through processes including machine learning, which are used for data mining of healthcare claims to find fraud and abuse, et cetera. So I think hopefully what will happen with COVID-19 is there is a lot more data available now than there was even in the since H1N1, and hopefully we'll be able to leverage this data in a transparent way that can really be used for anti-corruption initiatives, and that people will be able to share and mine that data, including civil society, for, again, the context of better transparency and fighting corruption.
Thank you all for those answers. And it actually, I think that, also thank you, Sarah, for the shout out of the CIPE's Anti-Corruption Rapid Response Project. I want to now go to a question from Johannes Thom at Global Integrity. He said that he appreciated Sarah's nudge to not primarily focus on corruption, anti-corruption as an end in and of itself, but to think about the function we want the health systems and services to fulfill for us as a society. So based on the clarity about those goals, we can then identify what corruption risks are priority, which risks need to be tackled. So Johannes asks, for Sarah specifically, but we can also open it up to others, but what is the level at which decisions about trade-offs are best made at the country level, at the state level, at the national level, or at the international organizational level? Yeah.
So there I would say there's not enough investment in anti-corruption in the health sector generally. Ideally, you should go as granular as is feasible, because the more granular you go, the more nuance you'll understand about the decision making and the various sort of informal networks and kind of pressures that are surrounding these particular decision-making points that then have, vulnerability to corruption. So I think the more granular you can go, certainly the better, but it's all a question about the feasibility. Mustafa can speak more to this, but the UNDP risk framework is applied at the national level, and that's turned out some very, very admirable examples. But Mustafa, I'm sure you have also some musings on this.
Thank you, Sarah. First of all, yes, I agree completely in what you're saying. And this is the advantage of using the risk management definition, because it's the impact of an adverse event on objectives. And I totally agree that the objectives of health systems is the health of the people. So whatever risk assessment we're doing, we're looking at as if corruption is the harm or the threat or adverse events to achieving our objective for healthcare. And this is the mindset. That's why I like this definition, because it links completely to things. So whenever you have a risk heat map, the impact should be calculated with the whole health outcomes also that Sarah highlighted, if it create access, quality, affordability, inequities. So this links both worlds, because of course working with anti-corruption communities in general, they are sometimes focused only on as an end, not an mean to have a sector approach. And that's why also we started moving from this generic strategies towards sector specific strategies. And back to the point of the granularity, of course, it depends on this process, because you can use it on a national level, but you can zoom it down to a specific hospital and you map the process around this hospital. So in one country, you spot like the bribe and the security is taking outside the hospital, which is not even in the healthcare part, because it depends where you would scope it. But due to the fact that you cannot focus on part of the whole system, so you have somehow to prioritize, and then you can zoom in the supply of market products and zoom in into the warehouse. Wherever you would zoom in, you can get this level of granularity. The whole idea is how you get these decision points, because this helps you to agree completely that if you don't have this level of granularity, you tailor your interventions. But then if you even go in such a micro level, you can then come back and scale it up, or even compare between different countries later on. And Tim, how technology would help us both in the assessment and in the mitigation? Because this is where always it comes. We always take around and end up in technology at your side whenever the assessment.
Yeah, I think the good thing about technology is a lot of it can be deployed at the local, regional, national, or regional level. A lot of the information we get on a lot of our scans of corruption-related activity are geocoded, and you can get a lot more community representation of the experience of corruption that can feed into a risk framework versus approaches where you use more qualitative work like focus groups, etc. So I think there's a lot of different layers of data that can be collected to inform a risk framework on multiple levels, whether it be local, regional, national, or global. And I also think that there is importance to have things like the Good Governance Medicines Framework from the WHO, some international norms that establish kind of a toolkit, and then countries then localize it based upon their own individual needs, and then communities can then localize it even more based upon their specific community-focused risk areas.
Thank you all. Johannes asked another follow-up question that I think, Tim, you touched on, but maybe if people have other examples of what the most promising mechanisms you've seen across all levels to coordinate effective responses to, number one, prioritize certain problems with a clear link to health outcomes, and then also B, to take coordinated action to mitigate corruption risks.
I'll take a first stab. And hi, a quick hi to Johannes Thon. Nice to see that you're here joining us. I hope that you're keeping well in Washington. So I just want to reiterate that the anti-corruption in the health sector is arguably in a very nascent stage, and dealing with sort of beyond sort of the informal payments and some of the issues in procurement. It's really sort of it's not made too many dents in the system yet. So with regards to sort of like some of the most promising examples, we have examples of indicative impact, not of like grand success. Obviously, when it comes to assessing risk and getting a sense of priorities for anti-corruption, the approach from UNDP is very demonstrable of what can be done using the risk-based approach, as far as getting a sense of what are your major pain points or points of vulnerability in a system. The Global Fund is also adapting this type of an approach to their anti-corruption and sort of trying to bake in anti-corruption into programming through fraud risk assessment. A lot of the research that's coming out of the SOAS anti-corruption evidence research in London, and I'm not as familiar with the Global Integrity ACE, but if it's anything like the SOAS one, I'm sure that there's a lot of evidence being generated there about incentives and understanding of informal networks. Mushtaq Khan looks specifically at political settlements in different countries with regards to anti-corruption and health, and how having a strong understanding of these informal networks and political economy can really help to be able to identify sort of the pain points or the factors and drivers at play. And then with regards to coordinated action to do effective anti-corruption work, I mean, it's very difficult at this point to with regards to a pandemic response, and this is really the first of its kind in a century. So we're all really learning. But I can sort of talk about sort of business as usual times, and I think that one of the greatest examples of a coordinated response for anti-corruption in the health sector and taking a sectoral approach is currently underway in Ukraine. And of course, it's not finished. It's really at this point indicative impact, but the health sector assessment that's been done and the anti-corruption mechanisms that have been put in place, and I could talk to you about for another hour if we were to carry on, but they've implemented basically an anti-corruption plan that prioritizes improving health outcomes as opposed to prioritizing zero tolerance. And they've hardwired the system to be sort of anti-corruption by default. So there's a report that will be coming out from the World Bank in hopefully by the end of the summer, the Global Anti-Corruption Report on anti-corruption, and there will be a case study specifically on Ukraine and the mechanisms beyond procurement that they've implemented in their health system to tackle corruption. So stay tuned for that.
So I might add here also one of the important things that I've seen on the ground functioning really well. Of course, I wouldn't say in the crisis, because this was for the crisis, is having this national multi-stakeholder task forces institutionalized, and when they have the combination of the anti-corruption community with the healthcare community. Because one of the biggest failures of response was this absence of common language between these teams and absence of trust. Because so this was one success, and the advantage of focusing on risk, it also makes people switch gears from this punitive approach, and then helps in building trust also between these two different groups. Because, you know, like usually the sector and the investigators are a bit not linked. So looking into how these teams come together, and as I've shown in the photos, sometimes the dynamic changes a lot and they start speaking reform, and they can start this multi-sectorial coordination mechanisms gradually if this team becomes coordinated and later institutionalized, especially, of course, if you can integrate, depending on the country context, civil society and private sector in that. So this a bit, I've seen it succeeding in doing this, building consensus on starting certain reforms. And the advantage of having these targeted reforms, you can create quick wins. And then when you calculate the impact that you could treat more patients and get more money, then you can build the case back to what we're advocating for, which is that it's about, again, health. So I think, of course, it's challenging now, back to the question that was raised by Anwar, how you set up this within a crisis mode something. We'll see, because we're trying to adapt this now.
Yeah, I think just another quick point there. I think it's sort of impractical to think that all of the mitigating or corrective or action has to take place in the midst of a massive global pandemic. It just really speaks to the need to have, or to in future to prioritize the issue of corruption in the health sector. And just on that note, I just would like to make a sort of name drop to the budding work between the WHO, UNDP, and Global Fund to establish a global alliance around this issue to do exactly what Mustafa has advocated, which is to bring together these two sectors, so health and the anti-corruption sector, so that we can actually start to have these important conversations and start to develop the types of mechanisms that are greatly needed in order to mitigate corruption in the sector. And then once we sort of have that sort of cooperation established, it becomes much easier to do that at the national level.
And this is Tim. Real quick, I'll add something because I think we're running a little bit out of time. And this is a preview to one of the comments later on from one of the users, the last one, that transparency initiatives really tend to work well, especially in the healthcare space. One quick example is the Physician Payment Sunshine Act in the US, where it requires disclosure of all industry payments made to physicians. And the reason why I mention this is, you know, when you get more data about which doctors are getting the most money from industry and which therapeutic classes are, it really helps to prioritize what the key problems are. It catalyzes research in the space, and it also has really impacted physician behavior. Physicians don't want to take a lunch or, you know, these micro payments because they may show up on a website somewhere. So they have the dual, you know, benefit of actually prioritizing kind of coordination across, you know, specific risk areas, but also changing behavior of the people who are subject to the corruption and activating civil society as well. That's another comment in the chat. So I think those are very powerful tools in the healthcare space, and they also can link directly to healthcare outcomes, because you know, if a physician is getting more money for opioids, for example, is that exacerbating the opioid crisis? So definitely that's one of the things I think transparency initiatives, either e-procurement, e-government, are really critical to mobilizing more effort.
Great, thank you, Tim. And I just wanted to touch on this last question related to civil society. Again, probably 1 or 2 sentence answers, just so that we can get everybody on their way on time. But so Ben Schmidt asks, in a recent interview with Jim Wasserstrom, he shared sort of practical strategies for countering healthcare corruption during a crisis. And one of his ideas or strategies was having local civil society groups monitor health service delivery on the front lines. What do you think? What kind of role do you think civil society groups can play to help reduce corruption during this pandemic? And do you have any sort of examples? Maybe just for the sake of time, if you have an example, that'd be great to lead with. Okay, great, thanks.
Hi, this is Tim. I'll lead off and let Sarah and Mustafa end. I'll just provide one example that I think civil society is really critical to enabling whistleblowers to bring claims associated with healthcare fraud and corruption. And one example is the National Whistleblower Center, which does a lot of work trying to help people, you know, bring whistleblower large lawsuits, things like that. And they have a global survey that says that widespread fraud in healthcare is occurring during COVID. And really what we need to do is have these civil society groups enable, again, more transparency, more accountability, and actually help whistleblowers bring these you know, crimes to, you know, to the public and to make sure that they don't happen again. So I would make a plug for whistleblowers and protecting them.
Agree with Tim completely. I would also advocate that the role of civil society can also be to essentially be sort of a history keeper of what's transpiring, be that in areas of procurement or in healthcare delivery or in other forms of corruption, like just monitoring, putting like bills that are being discussed in Congress or Parliament or wherever, that they're just like put under the most intense microscope. Because just as an example, during the Ebola crisis in West Africa, it was later found out that funds had been corrupted, and these were then retrieved back. So as much as it's not ideal, there is sort of a retroactive thing that you can do to pull funds back, so that, to be sure that they are then used appropriately later. But the only way that we'll know that is if someone is sort of there just being the watchdog and scrutinizing everyone's move. And I think the more organizations that are doing that, the more it will be a deterrent for people to behave in corrupt ways in the first place.
So may I add also, I have several experience in that. First, you can also, in addition to this whistleblowing, can use the civil society as an entry point. So in certain countries where really the government was disrupted at entry point, we did not wait till the government is established, but rather entered through a civil society, and where you use the civil society as a facilitator and advocacy group, reform group. And then another country even like kicking off soon in lines for integrity in healthcare, that's supporting bringing all NGOs together, and then they're starting to negotiate in the government. Had also like an participation in the assessments itself by being part of the task forces. And then back to this accountability point, or like when you reduce the risk of corruption, you want to make it more visible, like you make it less feasible and more visible. And this is where you can use also the civil society at the decision point level by strengthening accountability. So you can have it on a national level, you can have it as an entry point. I think we need like a full package, which we're trying to work on now also, on the role civil society can play. And the recommendation is also like to split between these different roles, because if you're a whistleblower or a pressure group is different when you are a community-based group or a service provider. Because don't forget that we have also a major role of civil society, for example, as recipients of grants. So we also, being a civil society, you know, like we really need also to support their capacity in having integrity in their cycles themselves. So I think like civil society is a pillar alone that we need to shed light on.
Well, that's actually a really fantastic note to end on. And it looks like we're at time, so it's good timing too, to have that nice comment about civil society as like a key pillar. I want to thank everybody very much for attending today and for asking such good and sharp questions that really brought out a lot of meat in the discussion. I also want to thank our panelists, Sarah, Tim, and Mustafa, very much. Thank you for your time and for your presentations, for your thoughts. I think that, well, I know that I learned a lot. I don't want to speak for everybody. I hope everybody else learned a lot too. But I'd also like to remind everybody that this session is part of a weekly series put on by CYPE's Anti-Corruption and Governance Center on different topics around COVID-19 and corruption. If you're interested in the subject, please reach out to us either by email, acgc@cype.org, or over Twitter. Our handle is @CYPE, CIPE_ACGC, and we'll sign you up for our WhatsApp channel devoted to the topic. It usually has one daily update, so it's not overwhelming. I know that sort of right now I'm overwhelmed by the flow of information, which Tim touched on in his presentation. I also want to give a big thanks to our team here at CYPE, who helps put on the events, these events every week. So those people are Caitlin Neucom, Ben Schmidt, Kai Bernier-Shen, and then Frank Brown, our team's director. And also thank you to Andrew for giving the opening remarks this week and every week. Okay. I said thank you a lot, but I'll say it one more time. Thank you all, and we hope to see you all again next weekend. And if you have any follow-up questions, feel free to send them to us. We can pass them along to the panelists. And yeah, have a great day, everybody, and be well.